Hello, I'm Aaron Lohr, host of the Endocrine News podcast. In addition to bringing you the latest research breakthroughs and clinical advances from experts in the field, we talk about education, advocacy, career growth, and more from the endocrine perspective. From bench to bedside, from graduate school to practice, from the doctor's office to Capitol Hill, we talk about it all, and it's free to you. So go to www.endocrine.org/podcast or search for Endocrine News Podcast on Apple, Google, or wherever you get your podcasts.
This is Endocrine Feedback Loop. I am your host, Chase Hendrickson, and welcome you to this Journal Club podcast series brought to you by Endocrine Society. Thanks for joining us as we explore an important article recently published in one of the Society's clinical journals. Welcome back to Endocrine Feedback Loop for our 6th episode. Today, we look at an upcoming article in the JCE&M investigating a hybrid closed-loop insulin delivery system. I'm excited to take a close look at the article itself, including the study design the authors use. Also, we will take time to hear more about where we are in the development of other closed-loop systems and think about how we will assess the data as more and more of these studies are published in the upcoming years. As usual, 2 endocrinologists join me today in this discussion for Endocrine Feedback Loop, and both have a strong background in this area. We represent a very diverse U.S. geography today. So I'm at Vanderbilt University in Nashville, Tennessee, where I practice general endocrinology and teach students, residents, and fellows. Our regular contributor for this episode is Steve Whitland. Steve is at the University of Rochester in New York, and his practice focuses on diabetes, particularly around the use of pumps and sensors. He's also a fellow Journal Club nerd and teaches extensively in the fellowship there, and so we share that interest. And our guest expert today is Ann Peters from the University of Southern California. Ann is a world leader in research in diabetes technology and is heavily involved in the development of closed-loop systems. Her experience here makes her the perfect person to help us both understand this article and to give us an overview of what is to come in this field. Everything we discuss today will be our opinions only and not those of our respective institutions or of the Endocrine Society. Our article for this episode is Artificial Pancreas with Carbohydrate Suggestion Performance for Unannounced and Announced Exercise in Type 1 Diabetes. It is currently an advance article from the Journal of Clinical Endocrinology and Metabolism to be published in the print edition in the upcoming months. The first author is Clara Vinyals from the Hospital Clínic de Barcelona in Spain. Steve will now lead our conversation through the author's introduction, which will help lay the groundwork for understanding both this investigation, but the field overall as well. So Steve, why don't you walk us through the intro?
Well, exercise has been known to be of multiple benefits for overall health. Not only fitness, cardiorespiratory fitness, but certainly in diabetes, overall improves glycemic control. However, in patients with type 1 diabetes, the response to exercise can be variable, and also it can be somewhat unpredictable. We have multiple approaches that have been used that the authors mentioned at the beginning of their article for managing both hyper and hypoglycemia in patients who are going to exercise. And the response to that exercise can be very dependent upon the circumstances of the exercise. And I was happily surprised when I did some background reading in this area to notice that one of the consensus guidelines written for exercise in type 1 diabetes was co-authored by Ann Peters, who's our guest today. So I had several questions that I wanted to ask Ann in relation to this article. One is, what is the expected hormonal response to exercise? And does the type and duration of the exercise influence what happens to the glycemia?
I've been really interested in helping people with type 1 diabetes deal with exercise because I want people with type 1 diabetes to just be people, right? And I want people to exercise. And I was lucky enough early on in my career to be referred a young man named Gary Hall Jr., who was in between the Atlanta Olympics and the Sydney Olympics. He was an Olympic gold medalist. He was a sprinter, and he got type 1 diabetes and was basically told he couldn't compete in the future. And it wasn't clear to me really what that meant or why people would say that. But exercise, at least sprinting or aerobic exercise, is all about getting fuel to working muscle. And you have to be able to do that in a way with an Olympian, especially an Olympian swimmer that does it within hundredths of a second. And so I was not really clear about exercise, but I quickly became a world's expert on exercise because I did it once. And the whole notion of exercise in type 1 diabetes has to do with basically the concept of insulin on board. Because if you go to exercise and you have a lot of insulin on board, that insulin is going to pull glucose into your muscle. And exercise also causes glucose to go into your muscle through the non-insulin mediated glucose uptake pathway. So glucose is going into your muscle. You're getting rid of your glycogen because you're using that as glucose. And so working muscle just depletes your body of glucose. You become hypoglycemic. So therefore, you have to have all sorts of strategies to reduce insulin before aerobic exercise and then during the exercise. So what happens is it's very hard to get to the right level to exercise. Then you start exercising, you can become hypoglycemic, and then you have to eat a bunch of carbs, and nobody wants to eat carbs because most people are exercising to be healthy, and eating more isn't good. And then after exercise, your glucose tends to shoot up. And it really depends on the intensity of the exercise and the type of exercise. So aerobic exercise brings down your sugar, but intense aerobic exercise, if you get a lot of catecholamine secretion, can bring up your sugar. And then things that are resistance training, weight training, high intensity interval training, all of that, boxing, that brings up your sugar because it increases the catecholamine response. So the best way to exercise if you have type 1 diabetes is to do resistance training first and then do your aerobic training, because that way your resistance exercise doesn't require that you mess around with your insulin levels. It just may bring up your sugars, and that gets you ready to do the aerobic part, and then you need to do a cool down. So there's an art to this. And the reason I loved this paper so much, it's about a study in which the system itself helps you figure out what to do. And I love the concept of what these investigators were up to because it may make it easier to exercise. And before I read this, I thought the only way you could make it easier to exercise was to give glucagon, to have a dual hormonal system, so you had a check and balance. But in fact, here you see that with just a single hormone, insulin, and the right balance of glucose gel, you can actually do almost the same thing. So I loved what these authors are trying to do to help people with type 1 diabetes exercise.
So what methods do we currently use to try to prevent glycemic variability with exercise other than carbs?
Well, so I have a whole program. So the current hybrid closed loop systems have a setting that's called exercise. And you've got to anticipate when you're going to exercise. And this is part of the problem because this takes away a lot of spontaneity. But an hour or two before exercise, you put the pump into the exercise mode, and that raises the target. So you get less insulin as time passes before exercise to reduce the insulin on board. The second thing I often do is to reduce the insulin dose the meal before the exercise, but that really only works if you're going to eat 90 minutes or so before exercise. And then I have people look at their glucose levels, and if they're, say, 140 going down before exercise, they have to eat some carbohydrates versus if they're going up. So I want them to be around 140 to 150 before they start aerobic exercise, but they also look at the trend arrows. So you have to do a fair amount of preparation, and ideally you'll do it an hour or two before you exercise. And I've dealt with a number of adolescent athletes, and I can tell you that adolescence is the hardest time to manage people with diabetes, but in particular when you say, remember to do this an hour before you exercise, they look at you like, what are you talking about? So what you want, and my goal is to make it possible for people with type 1 diabetes to exercise when they want to exercise, like you and I do, like when we're procrastinating and not wanting to do it, but we have to because we changed our insulin. So it's a great tool to be able to just exercise.
Later in the introduction to their paper, mention the program called SAFE-AP, SAFE-AP, and they say it's a proportional derivative system with carbohydrate recommendations that it generates, as you pointed out. What kinds of closed loop pumps do we currently have available?
Well, there are three, if you think about it. So there's the Medtronic 670G, which uses a Medtronic pump and a Medtronic sensor. So that's one hybrid closed loop system. It was the very first. The second is the Tandem system, which uses this technology called Control IQ and works with the Dexcom sensor, which is a better sensor, at least in my mind, than the Medtronic sensor. And then there's something called the do-it-yourself world. And they're the people who've taken an old Medtronic pump or an Omnipod pump. They basically make it talk to a Dexcom sensor with something called a Riley link. And you get the algorithm off of the internet and you basically build an app on your iPhone. And that's a really cool system. It's not FDA approved and I'm not recommending it to anybody. But I know as an endocrinologist, I'm allowed to adjust the system if it's for patient safety. I asked them at the FDA and they said that was okay. And it's amazing because it's infinitely variable. People can program it however they want, but that's for really people who are at the highest level of understanding. And it doesn't do this exercise thing as well as this system in this article seems to do, because you still have to announce exercise and you still have to have an exercise program. And if you think about it, because what I said is different kinds of exercise affect glucose levels differently, you could theoretically, if you were a real athlete, have one program for weight training, one program for aerobic, one program for mixed. It can become enormously complicated. So that's why a system that can figure it out without you telling it much is actually a really good idea.
So we've got all these systems, and they all use different algorithms to some degree. Does one have to use exclusively, for example, proportional derivative algorithm or a fuzzy logic algorithm, or can they be combined?
That's a really good question. So this is the deal. The first system was the whole Medtronic system, and it was a Medtronic pump and a Medtronic sensor and a Medtronic algorithm. And then the FDA decided, at least this is what I think they decided, was that it wasn't ideal for patients to be forced to use this piece, this pump, this sensor, this algorithm. But instead, what they did was they started approving the pieces. So they approved the sensors. So there's two sensors that are designated iCGM, which is interconvertible CGM. So you don't have to reapprove that device to have it be part of a system. So now you could choose an iPro2 or a Dexcom G6 sensor. And then there's, I think, two ACE pumps. I don't know why they're called that. There's some acronym there. But there's now two of those pumps, which is the Tandem pump and the Omnipod pump. And so eventually, when the pieces get together, you could choose this pump and this sensor. And then they're working on having the algorithm be something you can just get at the App Store to stick on your phone. So the logic, the system you use that interconnects the pump and the sensor is going to be up to you as well. And what I like about this, and when I give talks about the future of all this, is I have two subtypes of patients. I have the types of patients who want infinite flexibility. So they want to be able to have different targets and different exercise modes and have lower postprandials. And I don't know, they want to adjust everything. And I'm a nerd, right? And I love to adjust their systems to fit their needs. But I also have perhaps even more patients who don't want to be bothered. They want to stick something on their body and have it work. And in fact, they don't want to have to count carbs. They just want to put small, medium, and large in when they eat, and that's that. And then the thing figures all the things out it needs to. So I have a sense of a world, hopefully, where we have a lot of different algorithms, and depending on the patient's needs, their lifestyle, if they're pregnant, if they're athletes, they can choose the algorithm. But I must say there's commonalities amongst the algorithms. One of the things that's really important is that as a provider, you have to know which part of the algorithm you can tweak. So is it the carb ratio, the target, the insulin on board, the insulin duration, whatever it is, you can tweak certain things in different settings, but you learn the basics of the algorithms. And, I must say that I've learned so much in the past 2 years about these algorithms just because I have hundreds of patients who use them.
Okay, just one last point about the technicalities of the introduction. They mentioned that their system uses a sliding mode reference conditioning as part of it. What does that mean?
I puzzled that as well. So what I think it does is it anticipates where your sugar is going and where it would go based on insulin on board trends and if you eat carbohydrates on top of that. So it's taking all the parameters of both measured glucose, ingested glucose, and given insulin and figures it out and then tells you if you need to eat more. But that's just my idiot's guide to this algorithm. Somebody really, really smart figured this out. I mean, I'm really impressed, and it takes a lot to impress me.
And that would answer the question as to how the pump knows to generate a carbohydrate recommendation.
Yes, because it's figuring it out. And let me just step back for 1 second and tell you one of the really serious flaws that I see in the current systems. So even if you put your pump into exercise mode, and let's just say you're one of my real athletes and you're about to go out for a cross-country run, and you want to eat to get your blood sugar up to 200 because you're going to now run down your exercise, you're going to run down the carbs, and your pump doesn't know and can't sense what's going to happen. So instead of saying you're 200 but you're going to run, it says you're 200, I'm going to give you a bolus dose. So I've had people literally have severe episodes of hypoglycemia while exercising because they didn't realize the thing was going to fight them. So I had one woman go out for a hike by herself in the mountains, and search and rescue had to come and get her because the pump gave her this bolus and she wasn't aware she got the bolus, the auto bolus from the pump. So the thing you don't want is your system to give you insulin at the wrong time. And I think that these guys are trying to make sure that doesn't happen. And that's part of the magic of the system. None of this is perfect, by the way, but I think that's what they're trying to do.
So this study is a proof of concept study, and they acknowledge that what they're really looking at is safety as well as performance. And they really look at using the algorithm with both announced and unannounced exercise. And so they're going to have, as will be discussed in the methods, they're going to have 3 groups. They're going to have the group which is using what you and I would call sensor-augmented pump therapy. And then they're going to have the closed loop with announcement, the closed loop without announcement.
Yes, I think it was a great study design. And as you said, it's just proof of concept. But it's a great concept to try to prove.
Thank you both, Steve and Ann, for giving us an overview there. I think that very nicely illustrates the limitations in our current system, so why we need something else, why we can't be happy with where we're at right now, but also the complicated nature. There are a lot of different approaches to how to solve this problem, and we'll come back to this at the end, but we're going to have to start thinking about how we can compare very different systems as we get more and more of these studies. So we'll revisit that shortly. But first, we do want to take a closer look at the methods, as we typically do. And the first thing that I want to do is give an overview of a couple of different aspects that they use in a study design. And that's of having an open label study and then also using a crossover study design. So an important thing to know about with open label, so that is as opposed to blinding of a study. So when we think about often our gold standard studies, at least with typical medication interventions, are studies that use triple blinding. So nobody in the study knows who's taking the medication and who's on a placebo. So the subjects don't know, the individuals who are conducting a study working with the subjects don't know, and the evaluators looking at the data don't know. And that's as opposed to open label, where people, the subjects and the investigators, are aware who is being treated and who is not. And there's a couple of things that we always need to be thinking about in these scenarios, a couple of different biases that are particularly relevant, and that's performance bias and ascertainment bias. A performance bias is something that happens when the subject is aware that he or she is being treated. And because of that knowledge, being aware that they're on a medication or a new system in this case, then they might behave differently, and that might be driving the outcome, not specifically the intervention itself. And the other one, the flip side of that, is something that can happen to investigators, and that's an ascertainment bias. And that is when investigators, knowing that a subject is being treated or not being treated, or knowing how they're being treated, might look for outcomes differently. A lot of this is particularly relevant in subjective outcomes. We think about that with placebo effect that can happen whenever you don't have blinding. And then we also think about that when there are subjective outcomes that investigators are looking for. Fortunately, when you have more objective data, a lot of that is alleviated, but still potential biases that we need to be thinking about. And the other thing we want to consider is a crossover study design, since the authors use that. And I've talked numerous times, we've looked at a lot of observational studies in previous episodes, and observational studies by their very nature suffer from confounding. So a confounder is something, an aspect that's related to what you have labeled as your exposure of interest, but it's actually driving the outcome, as opposed to what you have studied as what you have proposed is the driver of the outcome. And the benefit of a randomized trial is that because you are randomly allocating people to be treated or not treated, it's not that the confounders go away. It's just that they are, if you have randomized correctly and have a large enough sample size, is that they are balanced between groups. So another way of thinking about it is they cancel each other out. And a crossover trial is the absolute best way of doing that, because in a crossover trial, the subjects all participate in all of the different groups. So each of your group, your intervention group, and your control group look exactly the same because they are the exact same people. So in that situation, when you cross over, then your confounders are perfectly balanced and they perfectly cancel each other out, and so that you don't have to worry about them influencing the outcome in one group more than another. So with that in mind, we'll look at the study design that these authors use. So they do use an open label. This is a 3-arm crossover, as Steve pointed out already. And the order of the crossover is randomized, which is an important aspect of that, because there can be a difference if you go through that sequence in a predictable basis, but it was not done in this case. It was randomized, so the subjects went through the sequence in different orders. So a word on the inclusion criteria: all of these individuals had to be between the ages of 18 and 65. They all had to have had type 1 diabetes for at least a year, and their A1Cs had to be between 6 and 8.5. And BMIs had to be between 18 and 30, and they had to have no advanced complications. So one thing I thought, that even though, as Steve has pointed out, this is a proof of concept study, I think we do always want to look at these inclusion criteria. A helpful thing to do is to think about how similar are these to the patients that we see. And so I'd like for Steve and Ann to comment, at least just so that we're thinking about it, how typical these patients are for the patients in our clinic, or are they not particularly representative?
Well, certainly in my clinic, since I do adult endocrinology, virtually all the patients are above the age of 18. And I think it's reasonable, although we do have a significant number of patients who are over the age of 65 who are on pumps and closed-loop systems or hybrid closed-loop systems. I think that's fairly representative. The A1Cs, and I believe the average A1C in this study came out to be 7.3%. I have a lot of patients that fall into that category, but there's certainly, I believe I'm not the only person who has these, a lot of patients who have hemoglobin A1Cs above 8.5% that we're asked to manage. And obviously, those patients, this study would not necessarily apply.
Yes, although these people also had to be really fit because they had to do these bouts of exercise and get their heart rate up above 70%. And I think that this is exactly, when I close my eyes, that sort of 40-some-year-old athlete who is fit enough, who is really wants to know about physiology and technology. And, I think of this as those patients. It's not all of my patients at all in my practice, but it is a subset of patients. And I think it's an appropriate subset to study because these are the people who could do the kind of exercise that will lead us to at least a beginning understanding of these systems. So I think that this struck me as a reasonable patient population for what they're trying to look at. But there are, and you and I am sure, get the same population of patients where there are some that are really hard to treat and some that are, a joy and easy to treat.
Good point. So potentially representative depending upon exactly how we're thinking about it and what subset of our patient population we're thinking about. Again, this is not a huge issue because this is a proof of concept study. The authors are not trying to say that this is definitive evidence on anything, but we always want to look at this and do consider the possibility of another bias, that being of the sample selection, is that maybe the individuals who are enrolled in a study don't represent the general population, but as Ann Riley points out, this may well represent a population that we would be particularly interested in using such a system for. Quick word on the exclusion criteria. These individuals could not have had a severe hypoglycemia or DKA episode within the previous 6 months. They could not have hypoglycemia unawareness and could not be either pregnant or breastfeeding. And the way that they worked in this study is that the individuals used a CGM, a continuous glucose monitor, for 6 days prior to the study of the exercise, and that was to optimize the settings. Now, we don't have a lot of information, really don't have a lot of the baseline data other than some of that A1C data that was mentioned already. And Steve, I know you had some thoughts about that on perhaps a little bit of a limitation on not fully understanding exactly the baseline data related to these individuals.
Given, I think that this constitutes a small group of patients, one would like to know some more information. have they had a previous ambulatory glucose profile, so we can get a feel for how their glucose variability was. We have an A1C. An A1C tells us what the average blood sugar is over 90 days. It doesn't tell us about glucose variability, whether a patient might or might not be prone to some hypoglycemia unawareness, although severe hypoglycemia unawareness was an exclusion criteria. So I think that more information, and as Ann pointed out, we're assuming that these people were extremely fit based on the fact that they were going to get up to 70% VO2 max. But we don't have that particular information that's given to us in the paper. Ann?
Yeah, I wasn't sure quite how they figured out that these were the 10 people that could do this study, because it's a hard study. I'm pretty sure I couldn't. I'd probably keel over, I mean, it sounds like you really have to be sure of your fitness. And then I think by corollary, you have to be sure of exercising with type 1 diabetes. So these were this already chosen subset of exercising humans with type 1. These weren't the couch potato that you're suddenly getting out of bed. You're actually dealing with fit people. And so I did wonder how they recruited. And, like I said, I can imagine who in my clinic I would pick, but it sure as heck isn't everybody. It's this one and that one and this one that would be part of this. So I think they come into the study knowing a lot about exercise to begin with, because they can do this intensive exercise. Either that or they're just born gifted athletes and, they're not expressing it. I don't know.
Good. So another important caveat to be thinking about here. So as was mentioned already, so there are 3 groups that all 10 of these individuals participated in. And the first group was the closed loop system with unannounced exercise. Another one was the closed loop with announced exercise. So in advance of exercising, you notify the system that you're going to be exercising. And then the final one, the comparison group, was an open loop system, a sensor augmented pump with announced activity. And another important point is that there was a washout period of 1 week, of greater than 1 week, between all of these groups. And as we said before, it was randomized as to what order they went in. And the procedure for the day where the study of the exercise took place is that at 8 o'clock in the morning, the standard 50 grams of carbohydrate were taken in. And then at 8:30, the system was activated with exercise starting at noon. And the exercise consisted of 3 15-minute cycles of the ergometer, where they would reach 70% of a maximum heart rate. And there would be a 5-minute break between these sets, and they were closely monitored. And then the exercise announcement, where that was applicable, was 20 minutes before the activity. And then with the open loop system, that took the form of setting the basal rate temporarily at 0%. So a question for Ann, you talked about the exercise before. So this description, for a lot of us who don't think about these descriptions of exercise, how would you describe this type and intensity of exercise, and what would we normally expect the glucose effect to be based on that?
Well, my problem with exercise is that it's so individual in terms of the impact, and it differs so much by time of day. And they actually standardized the time of day. So they were after eating that 50 grams of carb breakfast. And I think the most important part of the results, I'm not sure we're supposed to jump there, but I'll give you my take on what they were doing in advance, was figure 1 basically shows that all of them started out with a glucose level of about 150 to 180, 60 minutes before the exercise. And all of them are coming down. Their glucose levels are dropping before the bout of exercise starts. And so I think that's pretty typical in what you see in patients who are starting exercise after a meal. Now, arguably, you wouldn't want them to be falling as they're starting to exercise. But even in the group where they were notifying the system that they were going to exercise in an hour, it wasn't able to reduce the insulin on board quite enough to prevent the sugar from falling going into the exercise. But it suggests to me, just looking at the graph, that it may have prevented more of the fall during the exercise. So I think it is very similar to the way a lot of my athletes come into it, where they've eaten, they try to reduce the insulin on board one way or another, and then by the time they get to exercise, they want to be around 150. These guys started out a little bit lower than that, and then they have to figure out how much carbohydrate to eat while they're exercising, not to go low. So the way these people came into this looks a lot like a lot of my patients do. But again, it's so variable in terms of how people adjust for exercise. But the concepts, I think, are the same.
And Ann's comments on what individuals who are exercising try to do manually is a really nice segue into how this closed loop system worked, is that it did have two components. So it had a component of a basal rate adjustment, but then it also had a component of a recommended carb intake. So it's recommended a standard intake of 15 grams of carbohydrates as needed based on the system in order to try to prevent this hypoglycemia from happening. And then as we take a look at what endpoints were studied here, so the primary endpoints that were used were percentage of time less than 70, so defining hypoglycemia as that, but then also the number of hypoglycemia events, and that's up to 180 minutes after the start of exercise. Several secondary endpoints that were used as well, so looking at the percent time in range, the variability of the glucose, the total amount of insulin used in each system, and also how many carbohydrates were consumed in each of those systems. So before we wrap up the methods, just wanted to hear from Steve and Ann if there were any other pieces of information. So that was the information that's going to be relayed in the results. Anything else that you would have liked to have known as far as results go, other important information that would have helped you assess these different systems?
I'd be interested in asking Ann, and I only noticed this when I reread the paper. The exercise was actually done at noon, which means it was pre-lunch because these folks all ate breakfast by 8 o'clock in the morning. And so my first question was, how typical is it to see patients who do their intensive exercise just before lunch? And the other question that I really had, and this is not a question, it would be a question to the authors, in the open loop system, they put the patients on their temporary basal rate or suspend just before the exercise. And I think we typically recommend that the suspension occur before because there's a delay between what the pump is doing and when the actual insulin hits the system and starts working. So I'd be interested in her thoughts on that also.
That was fascinating that you picked up that this was that many hours after breakfast. I thought it was closer to breakfast. But then it makes me wonder, how high were they after breakfast? Because they're still falling. But what also I don't know, and the authors state this as a weakness, is we don't know what they actually ate for breakfast. And if you eat sort of lower glycemic index carbs, like some form of superstarch, or, a lot of my athletes play around with what do they eat for the meal before so that they can sustain the carbohydrates through exercise, and then what do they eat as simple carbohydrates during exercise. So the actual composition of the meal matters. And I would have thought that they would have exercised within 90 minutes of eating breakfast. So this is a little bit delayed, and they are making adjustments. But I don't think you can do this without making some adjustments. I mean, otherwise you'd go too low. But it's not as though there's a real control group in a way. So as a way of background, a really genius exercise physiologist named Mike Rydell, who's up in Canada, did this study in a sports camp for kids. And this was done probably 10 years ago. And they were wearing continuous glucose monitors. And he made an entire algorithm for how low the sugar was, where the trend arrows were going, and whether he should give them, 5 grams of carbs, 10 grams of carbs, whatever. And he did this to kids racing around in a field. And he was amazingly accurate at giving those kids the right amount of carbs based on their CGM, the trend arrows, and their glucose levels. And it's almost like this algorithm takes what was in Mike's brain and puts it into a hybrid closed loop technology system. Because at the time, when I first read his article, I thought this is great because it gives me some guidance as to how to tell my athletes to consume carbs. But this is giving it to the person in real time from their pump. And so this is like having a research scientist at your side saying, here, eat 5 grams of carbs. And that's what I like about it. And it mimics what Mike did with this really difficult population of kids, a number of years ago. So it's the same concept that we've all been working towards.
Good. And a final word on the methods here and the statistical analysis. The authors point out that they didn't do a formal sample size calculation, and I think important to note that. But fits with this being a proof of concept study is that they're not primarily interested in trying to prove statistical significance in their findings. So with that overview of the methods, we're going to turn it back over to Steve, who's going to walk us through some of the results we've already heard a little bit about, but we're going to hear a lot more about that and then give you some of our own thoughts after that.
So, as we've mentioned, there were 10 subjects in the study. One of the subjects was not included because they were not able, for technical reasons, to wear their continuous glucose monitor for more than 60% of the time. Otherwise, they were well matched in terms of the duration of pump use and age. They were about 40 years old. As I had mentioned earlier, their average A1C was 7.3%. So these were reasonably well-controlled patients. And they were matched for daily insulin use. And they wore the continuous glucose monitor 93% of the time, which is not always a feat that one can accomplish. The glycemic outcomes that they looked at, and particularly hypoglycemia, were not statistically significant, but given the nature of the study and the fact that the study was not particularly powered, it was just a proof of concept study, that's sort of to be expected. But certainly, especially when they're using multiple outcomes, you would need correction for multiple outcomes measured, and then there's certainly no statistical significance either. There was no significant difference in the insulin requirements. By using the Yellow Springs instrument, which is sort of the gold standard for measuring glucose, there were 15 hypoglycemic events. There were 4 in the group that had the closed loop with no announcements. There were 3 in the closed loop with announcements. And then there were 8 in the open loop pump. So the closed loop appears to be better, but that's a descriptive outcome. Interestingly, the continuous glucose monitoring data showed no events of hypoglycemia in the closed loop system and 16% in the open loop system. And one interesting aspect of this was the continuous glucose monitor missing hypoglycemia that was detected by the Yellow Springs instrument.
And I'll chime in there, Steve. And when I was looking at those and some of the numbers, and I think part of the challenge in that comparison is the way that the authors reported that CGM data is they reported the median data. So in a way that was certainly appropriate, because we'll often think of averages when we have different groups. We'll think of averages, and that is best used when there's a normal distribution of the data. And looking at some of these numbers, it does not appear that there is a normal distribution. So then you have to find other ways of presenting that data, and a median would be a much more typical way of doing that. But then the problem is that, so if you've got 10 people in all these groups, it's all the same people, but in then 2 of these closed loop systems, less than half of the people had hypoglycemia. So then if you're looking at the median percent of time spent hypoglycemia, you're going to have 0% there. And then it makes it really challenging to try to compare that to the open loop system, which had the 16.2% time. And I think so. Anne has already mentioned the figure, and I think that gives you a much better sense of the time spent with each of those groups as hypoglycemia. But it does make it a little bit more challenging to try to compare glucose reports of number of hypoglycemic events and then its percent time and range, particularly when it's a relatively uncommon thing to happen with the closed loop systems for these individuals.
That actually made it much clearer, because when I was reading the results, I got a little confused about what the authors were comparing and how and why. So thank you for that explanation. But it's actually true that exercise itself can impact the sensor readings, because you are looking at interstitial glucose, which is different than capillary or plasma glucose levels. So there is, in some cases, a skew between the two. The real question is the clinical one. Can you guide treatment based on the CGM data during exercise episodes? And here it clearly seemed that it did work and could work as a proof of concept. Whether this goes forward and really helps people is another question, but it did seem to help guide people as to what to do, which is the part I like the most.
Looking at other outcomes, the time in range was 88% for no announcement and 92% for an announced in the closed loop system. And the sensor augmented system, 81%, which parenthetically, and although this is very, very short-term data, 81% is well above the international consensus guideline of 70% that one wants to see time in range. The time below range, they mentioned, none had less than 54 milligrams per deciliter, which is sort of the numeric definition of severe hypoglycemia. There were no episodes in the closed loop system and 16% in the sensor augmented system. In terms of the coefficient of variation, again, the closed loop system, the no announcement was 26 milligrams per deciliter, and the announced system was 22 milligrams per deciliter, both of which are well below what's recommended, which is good. The sensor augmented system clearly had twice the variability. It had a coefficient of variation of 46 milligrams per deciliter. Now, Anne alluded to the clinical relevance of this. So they looked at the need for carbohydrates. And interestingly, the no announcement had 15 gram requirement. The announced had 22.5 grams requirement. And the sensor augmented pump had a 32.5 gram requirement. So really, the proof of concept was that I think as a concept, the closed loop system looked better than the sensor augmented system. But it's interesting to me that it's not clear cut that the announcement versus no announcement made a big difference.
Good. So now, after thinking about those results, we're going to take a look at the discussions and conclusion. And as we usually do, we'll start with the author's conclusions, and then we'll give you some of our own thoughts about those conclusions, but then also try to put that in the context of clinical practice. And if not a change now, might this be a change soon for us? So first of all, with the author's conclusion, so the way that they describe their system is that this data shows that it is effective and safe, is the way that they describe that. They suggest that the use of carbohydrate recommendation was as effective as potentially a substitute for glucagon. And if we think about other systems that are in development, so having systems that have dual agents, both insulin and glucagon, that conceptually it's the same idea, is that you're introducing something, giving something to the patient so that their glucose will increase. And they suggest that having someone eat carbohydrates is effective instead of having a pump that delivers glucagon. They point out that the system reduces hypoglycemia, that it reduces variability of the glucose, and then also, as Steve just pointed out, it reduces your need for carbohydrates, so that if taking it in advance to prevent a low actually leads to less carbohydrate intake than trying to treat it once it has already occurred. A few of the limitations that the authors point out, as we've mentioned numerous times, this is a small sample size. It's a proof of concept study. They also point out this is a very controlled environment. So this is not a typical exercise setting that individuals would go through. We don't have any nighttime data, so we have data up through 3 hours afterwards, but we're not able to assess any longer term effects that the exercise would have and if the system would be helpful with that. And then another potential limitation is that the comparison group, the sensor augmented pump, was relatively rudimentary. So it did not include a system that had a predictive low glucose suspend. And that could potentially have some impacts, well, not perhaps as much during the exercise itself, since the basal rates were set at 0%, it could have an impact after the exercise is over. And while most of the lows in that comparison group did happen during the exercise, some of them did happen soon afterwards. So could have an impact there if they had used a more modern, state-of-the-art system as a comparison. So when we think about that with our conclusions as we compare our thoughts about this to what the author said, I would probably nuance just a little bit. And I think this is something that often happens. We have to be careful about how strongly we're stating something. I would probably nuance the author's main conclusion is to say that this investigation would suggest that this system is safe and effective. Certainly there's nothing worrisome about it. And looking at the point estimates, it would suggest that it is better. But because the sample size is small, when it's a proof of concept study, you can't really be definitive about something being safe and effective, though very encouraging data and what hopefully future studies could support this idea that was shown here. And then I think another one we just talked about is that it is hard to compare if we're not using our current best technology to the systems that they are developing. It's hard to know for sure that these systems would perform better than currently the options that we have available. And Steve, I know you had some other thoughts as well, particularly about the type of exercise that was studied here, and then also just maybe some limitations on how much of the data that we have available.
I think that Ann and I have both alluded to this, but this study looks at a very particular type of high-intensity exercise and a specific duration of exercise, and follows them only for 3 hours after the exercise. So in terms of applicability, I think that this is an interesting concept and it's a good start. But I think we need a lot more data under a lot of different circumstances. And this system may work well for this particular exercise and not work equally well with a different form of exercise. What if someone goes and jogs for an hour or does a half marathon? We have no information as to how this is going to work. I think that is really the most salient point here, that this is a proof of concept and there's a lot of work to be done. There is a discrepancy, despite the fact that it's probably explainable, between the YSI blood data and the CGM hypoglycemia data. And as Ann points out, what's relevant is what's clinically important. Although this was a Dexcom G5, and the question is, was the G5 missing hypoglycemia that the YSI was picking up? And obviously it was, because the YSI is the gold standard. As you alluded to, we have no nighttime data. And one of the important things about exercise, and then Ann can comment on this, is that the effect of the exercise lasts for up to half a day or more after the exercise is completed. And we have no nighttime data. Again, they're exercising at a peculiar time of the day, and it's a very specific time of the day. And as you mentioned, Chase, they kind of picked a straw man for their first go-around, i.e. a sensor-augmented pump without predictive alerts, which is several generations behind what we currently have available at the present time. So, and given the small numbers, I think we'd like to see this reproduced in larger numbers. And my query is that might other physiologic measurements, which have been used in other closed-loop systems, such as heart rate, etc., be useful to refining this even more? Or is this system enough? I think that what we can conclude is, thus far, in this small, select sample, it was to a degree effective and safe, and that the use of carbohydrates was effective, and that the closed loop appeared to reduce hypoglycemia.
And I think we can certainly agree that with the challenge that you two really outlined nicely at the very beginning of hypoglycemia and exercise, when we try to encourage people to exercise but don't always have good strategies for how to combat that, or at least effective strategies, that really any data is a good and promising addition. So certainly exciting from that perspective. So what I would like us to do as we wrap up is to think about the possibility of this changing our practice. So first of all, thinking about this study in particular, and I want to ask both Ann and Steve, so what would our thoughts be about this data? Do we see that this is potentially promising and exciting, or really don't know just because it was such a small study? So how would you two think about this, particularly in terms of future investigations into this?
Well, so what I see looking at this is not something quite so complicated. I don't actually care about what they compared it to. I care that both announcing and not announcing exercise gave you almost the same response. And I also care that this made it easier. So I would argue that my really elite athletes have figured out how many grams of carbs to eat when and blah, blah, blah. They know what to do. But this is for the person who's decided that they're inside for COVID too much and they want to go out for a jog. And this thing actually worked. They didn't go too low. A hybrid closed loop system, even the way they currently are still really difficult when it comes to exercise. This is a problem for current systems. Because this system is kind of simple, it basically did what it did based on those really amazing algorithms. But what really happened was I said, eat some carbohydrates. And you know what? That worked. And so I like this because it looks like it would keep my patients safe. It would encourage them to exercise, and they didn't have to eat all those carbs that they often do because they knew how many to eat. So I feel like this is a glimmer of hope to make exercise easier. And again, it's not going to fix it, and it's not going to be for the real athlete, but for people where they feel hampered by hypoglycemia and issues of fear of exercising, this might actually be something that makes it more possible. And all of the hybrid closed loop systems need to evolve in terms of their ability to handle exercise, and giving carbohydrate at a fixed dose at a fixed time because of a change in glucose might really help people. So that would be my hope, and that would be how I hope it's used clinically if it comes to fruition.
So Anne, help us then a little bit more as we really take a step back. So we've been focusing mostly on this study, but there are numerous of these systems in development right now. And many of them have very different approaches. We alluded to some of them before. Some of them include glucagon and these fully closed loop systems. Some of them are insulin only. It's possible that if this continues to develop, we could have a fully closed loop system, but that perhaps that it still does utilize some recommended carbohydrate intake. So we could have numerous different approaches, and we may not have direct comparisons of one system to another, and yet, and hopefully in a few years, we'll have several of these options available, and we'll have to decide and sort through all of this data and try to figure out what we're going to recommend for our patients. So how do you see that working out over the next several years once we start getting more and more of these studies, larger studies that are intended to show clear clinical outcomes? How are we going to decide which of the systems are superior? And as you have so helpfully pointed out over and over again, when we're thinking about providing care to the patient in front of us, how are we going to select a system to recommend to our patients?
Well, some of it is as simple as complexity. So some patients want a patch pump that sticks to them, and some patients don't mind the tubing. But more than that, I think we as clinicians have to feel what these systems are like. And I've watched a lot of my patients use one system and then another system, and patients will settle on something that works for them. And then I'm always wanting the next step better. But I think it's going to be very individualized. And when we get systems that are dual hormonal and have glucagon, I've always been dying to use those systems because I love the data. We just have to get stable, soluble, safe glucagon that we can infuse subcutaneously along with the insulin. But sort of hormonally, it makes sense to me to have dual hormones. But we'll see. And maybe giving pramlintide along with insulin. I mean, it is possible that there's all sorts of ways that we should be doing this. But every single step we add, it makes it harder for my underserved patients to figure out, right? I work a lot in East Los Angeles where the simplest is the best. And if I have to start filling 2 reservoirs with 2 kinds of insulin and calibrating and doing that, that's going to be way beyond what most of my patients in those underserved communities can do. So what I say is how wonderful that we may have an explosion of algorithms, types of pumps, delivery systems, because it will let us give our patients options. And right now, we've had so few choices, and it's just going to get more and more. And I'm really excited about the future, and I think studies like this are beginning to ask and answer the questions we need to address. How do we make exercise easier, safer, and better for our patients with type 1 diabetes?
Good. I like that concept. So it's less, do we have data directly comparing one system to another to prove that one is better, versus we have data that suggests that a system is effective, and then hopefully we have multiple options, and then we can help our patients figure out, customize that to them, and which one best fits their needs, their lifestyle, the demands that they have, and what they're looking for in a system. I think that's very helpful conceptually for us to keep in mind over the upcoming years.
I think we actually are doing that now with a very limited number of choices. We offer a patient, for example, an Omnipod pump, a Medtronic pump, a Tandem pump. Right now there are 2 closed loop systems, but I anticipate that soon there will be 3. And really, it depends on the patient's preference. Does the patient like tubing? Does the patient not like tubing? Which sensor do they like better? And I think that there will just be more variables, but patients will be making individual decisions.
And with that, I would like to thank Steve Whitland and Ann Peters for joining me for this month's edition of Endocrine Feedback Loop. I learned a great deal and hope that you all did as well, and I hope that you will look for our next episode to be released in mid-November. And now you're in the loop. This has been Endocrine Feedback Loop. Endocrine Feedback Loop is brought to you as a members-only benefit of Endocrine Society with special production oversight by Maggie Graham.
Hello, I'm Aaron Lohr, host of the Endocrine News Podcast. In addition to bringing you the latest research breakthroughs and clinical advances from experts in the field, we talk about education, advocacy, career growth, and more from the endocrine perspective. From bench to bedside, from graduate school to practice, from the doctor's office to Capitol Hill, we talk about it all, and it's free to you. So go to www.endocrine.org/podcast or search for Endocrine News Podcast on Apple, Google, or wherever you get your podcasts.